This picture is an image of an angiogram. The picture A shows an occluded coronary artery, and then the picture on B shows the same artery that is now open after percutaneous intervention or angioplasty with stent placement. When ischemia is prolonged and not immediately reversed, ACS or acute coronary syndrome develops. ACL includes the spectrum of unstable angina, non-ST segment elevated MI, and an ST segment elevated MI, or a STEMI. When patients first present with chest pain or angina, ST elevations on the 12-lead EKG or ECG are most likely indicative of a ST elevated MI or a STEMI. The ECG should always be compared to a previous ECG or EKG whenever possible. For patients with chest pain or angina who do not show ST elevation or ST wave changes on the EKG, it is difficult to distinguish between unstable angina and a non-ST elevated MI until serum cardiobiomarkers are measured, cardiac enzymes. On the cellular level, the heart becomes hypoxic within the first 10 seconds of a total coronary occlusion. Heart cells are deprived of oxygen and glucose needed for aerobic metabolism and contractility. Anaerobic metabolism begins and lactate acid accumulates. In ischemic conditions, heart cells are viable for approximately 20 minutes. Irreversible heart damage starts after 20 minutes if there is no collateral circulation. ACS is caused by a decline of a once stable atherosclerotic plaque. The previously stable plaque is going to rupture, releasing substances into the vessel. This stimulates platelet aggregation and thrombus formation. This area may become partially occluded by a thrombus or totally occluded. Partially occluded is going to manifest as unstable angina or a non-ST elevated MI, and an occluded thrombus will manifest as a STEMI or an ST elevated MI. What causes a coronary plaque to suddenly become unstable is not well understood, but systemic inflammation is thought to play a role. Patients with suspected acute coronary syndrome require immediate hospitalization. Unstable angina is chest pain or angina that is new in onset, occurs at rest, or occurs with increasing frequency, duration, or with less effort than the patient's chronic stable angina pattern. The pain typically lasts 10 minutes or more. Prompt treatment is needed for patients suspected of having unstable angina. The patient with previously diagnosed chronic stable angina will describe a significant change in the pattern of chest pain. It will occur with increasing frequency and is easily provoked by minimal or no exertion, during sleep, or even at rest. Unlike chronic stable angina, unstable is unpredictable and must be treated immediately. Despite efforts to increase awareness, women's symptoms continue to be underrecognized as heart-related. These include fatigue, shortness of breath, indigestion, and anxiety. Fatigue is the most prominent symptom. However, all these symptoms can relate to many different diseases and syndromes. It is because of these reasons that women often present with UA before CAD is diagnosed. In addition to the patient's history of pain, risk factors, and health history, the primary diagnostic studies used to determine whether a person has UA or an MI include an EKG and serum cardiac biomarkers that are lab blood work. The EKG or ECG is one of the primary tools used to diagnose unstable angina or a myocardial infarction. Whenever possible, it should be compared to a previous ECG or EKG. Changes in the QRS complex, ST segment, and T wave are caused by ischemia, and infarction can develop slowly or quickly with UA or MI. The EKG must be read carefully. and since changes can be absent or subtle at first. For this reason, serial 12-lead EKGs are done. This just means that there'll be EKGs done maybe twice a day or every day, just to see a clear picture if there's been a change. For diagnostic and treatment purposes, it is important to distinguish between a STEMI and a non-STEMI or unstable angina. An ST elevated MI or STEMI, patients usually have a complete coronary occlusion. ST elevation is first seen on the 12-lead ECG. Within a few hours to days, T-wave inversion and pathological Q waves develop. Patients with non-STEMI or unstable angina usually have transient thrombosis or incomplete coronary occlusion. These patients often develop ST depression or T-wave inversion on the initial ECG. They usually do not develop pathologic Q waves. Because an MI is a dynamic process that evolves over time, serial ECGs are done to show the evolution of ischemia, injury, infarction, and resolution of the infarction. Serum cardiac biomarkers are proteins released into the blood from necrotic heart tissue after an MI. These biomarkers are important in the diagnosis of MI. The onset, peak, and duration of the levels of these biomarkers are shown in this graph. These are cardiac isoenzymes. They're blood work that we check when patients present with suspected acute coronary syndrome. Cardiac-specific troponin has two subtypes, cardiac-specific troponin T and cardiac-specific troponin 1, or I. These biomarkers are highly specific indicators of MI and have greater sensitivity and specificity for myocardial injury than creatinine kinase, or CKMB. Serum levels of TN1 or TNI and TNT increase 4 to 6 hours after the onset of an MI. They peak at 10 to 24 hours and return to their baseline or normal over 10 to 14 days. Serial cardiac biomarkers, or cardiac enzymes, are drawn over 24 hours, usually every 8 hours times 3. The presence of biomarkers helps to differentiate between a diagnosis of angina and a non-ST elevated MI. CK levels begin to rise at about 6 hours after an MI, peak at about 18 hours, and return to normal within 24 to 36 hours. The CK enzymes are fractionated into bands. The CKMB band is specific to heart muscle cells and help to quantify myocardial damage. Myoglobin is released into the circulation within 2 hours after an MI and peaks in 3 to 15 hours. Although it was one of the first serum cardiobiomarkers to appear after an MI, it lacks cardiac specificity. Its role in distinguishing MI is limited because a lot of times patients who have fallen and maybe have laid on the ground for 12 to 24 hours, they can actually have elevations in myoglobin. So it's just specific to skeletal muscle. It can be elevated in an MI, but it's not the only indicator and it's not the most specific. The troponin is the number one indicator for an MI. The patient with a STEMI must undergo coronary angiography within 90 minutes of presentation or receive thrombolytic therapy within 30 minutes in agencies without PCI capability. This will open the totally occluded artery and limit the infarction size. The patient with unstable angina or a non-ST elevated MI may or may not undergo coronary angiography to evaluate the extent of the disease. Guidelines suggest that it is reasonable to do coronary angiography on stable but high-risk patients with unstable angina or non-ST elevated MI within 12 to 72 hours after presentation. If appropriate, percutaneous coronary intervention is performed at this time. Some patients may be treated only with conservative medical management. When the ECG and serum cardiac biomarkers or enzymes do not confirm an MI, other measures for diagnosing coronary artery disease are considered. To assess for ischemia or infarction, pharmacologic stress testing may be done when a patient has an abnormal but non-diagnostic ECG and negative biomarkers. It is extremely important to quickly diagnose and treat a patient with ACS or acute coronary syndrome to preserve heart muscle. You need to obtain a 12-lead EKG and start continuous ECG monitoring. Position the patient in an upright position unless contraindicated and initiate oxygen by nasal cannula to keep oxygen saturations above 93%. In the past, we would put oxygen on anybody who has chest pain, but they felt that doing that, just putting oxygen on anybody, wasn't really beneficial. So if the patient needs oxygen, supplemental oxygen, to keep their oxygen saturation up, that's acceptable. We need to establish an IV route to provide any access for emergency drug therapy. And we can use sublingual nitroglycerin and aspirin somewhere between 162 and 325 milligrams, chewable if not given before arrival to the emergency room. A high-dose statin or Lipitor is started if not already taken prior to hospitalization, and morphine can be given for cardiac pain or chest pain if unrelieved by nitroglycerin. The patient will usually receive ongoing care in a critical care telemetry unit where continuous ECG or EKG monitoring is available. Dysrhythmias or irregular heart rates are treated according to agency policies. We need to monitor vital signs, including pulse oximetry, frequently during the first few hours after admission and closely thereafter. We need to maintain bed rest and limitation of activity for 12 to 24 hours with a gradual increase in activity unless contraindicated. For patients with unstable angina and non-STEMIs, aspirin and heparin are recommended. Dual antiplatelet therapy with aspirin and Plavix and heparin are recommended for non-STEMI patients. Cardiac catheterization with possible PCI or percutaneous coronary intervention is considered for both UA and non-STEMI patients once the patient is stabilized and angina is controlled or if angina returns or increases in severity. Initially, patients may be NPO or nothing but mouth except for sips of water until stable. That is, until they're pain-free and their nausea, if they have it, has resolved. You can advance the diet as tolerated to low salt, low saturated fat, and low cholesterol diet. We must obtain the following health information from the patient who has arrived with chest pain. A past medical history or health history, a previous history of coronary artery disease, chest pain or MI. We would see if they have valvular disease, a history of heart failure, hypertension, lung disease, or increased incidence of hyperlipidemia. We're going to look at their drugs. Are they taking antiplatelets like Plavix and aspirin already? Anticoagulants like Coumadin or warfarin? Are they taking short and long-acting nitrates? Are they on ACE inhibitors, beta blockers, any types of vitamins and herbal supplements? We're also going to look at their history of present illness. We need a description of the events related to current illness, including any self-treatments and response. We're going to also obtain the following health information related to pertinent functional health patterns. We're going to look at their family history of heart disease, sedentary lifestyle or tobacco use, or any environmental exposure to smoke. We're going to look at their nutritional components. Do they have problems with indigestion, heartburn, nausea, vomiting? Any problems with urinating or frequency or straining when they have a bowel movement? Activity. When they're exercising, do they have palpitations, chest pain, Any weakness or dizziness? How is their chest pain? Can it be described as aching, sharp, or deep? And does it radiate? And then coping stress. What's their stressful lifestyle? Do they have situations where there's depression, anger, anxiety, or feelings of impending doom? So we need to perform a focused physical assessment for the following clinical manifestations. A lot of them are key with any kind of cardiac event, especially chest pain. Anxious, fearful, restless. They've got cool, clammy, pale skin. Their heart rate can be either elevated or, in severe cases, slow. Do they have a pulse deficit? Do they have an irregular heart rhythm? And do they have any type of irregular heart sound, murmur? And do they have problems with their blood pressure being too high or too low? So some of the nursing diagnoses that we might see with coronary artery is decreased cardiac output related to an altered contractility, an altered heart rate and rhythm if the patient has abnormalities. Acute pain related to the imbalance between oxygen and the oxygen supply and demand. Anxiety related to perceived or actual threat of pain, death, and activity intolerance related to general weakness secondary to the decreased cardiac output or poor lung and tissue performance. The overall goals for a patient with ACS include relief of pain, preservation of heart muscle. It means we want to take care of the occlusion or the blockage immediately, immediate appropriate treatment, effective coping with illness-associated anxiety, participation in a cardiac rehab plan, and a reduction of risk factors, modifiable. If your patient is experiencing angina, we need to make sure that we perform the following measures. Position the patient upright unless contraindicated, give oxygen as needed, assess their vital signs. We need to obtain a 12-lead EKG, provide prompt pain relief with nitroglycerin followed by an analgesic if needed. We're going to assess the heart and breath sounds. And the patient, we are going to expect they're probably going to be anxious. Their skin's going to be cool to the touch. They might have an increase in their blood pressure and a heart rate. Auscultation of the heart may reveal some abnormal heart sounds or extra heart sounds like an S4, S3. A new murmur heard during an anginal attack may indicate ischemia of a papillary muscle of the mitral valve. The murmur is likely to be transient and disappear when symptoms stop. We need to ask the patient to describe the pain and to rate it on a pain scale of 0 to 10 before and after treatment to evaluate the effectiveness. We need to support and reassure the patient, use a calm approach to help reduce the patient's anxiety during an anginal attack. The patient with a long history of angina should be reassured that a long active life is possible. Prevention of angina is preferable to its treatment. This is why teaching is important. You need to give the patient information regarding CAD, angina, precipitating factors for angina, risk factor reduction, and drugs. We must give the patient instructions on how to avoid or control precipitating symptoms or factors. For example, teach the patient to avoid exposure to extremes of weather and heavy, large meals. If a heavy, large meal is eaten, tell the patient to rest for 1 to 2 hours after the meal because blood tends to be shifted to the GI tract for absorption and digestion. We need to help the patient to identify personal risk factors for CAD. Once known, we can discuss the various ways modifiable risk factors can be reduced. We need to teach the patient and caregiver about diets that are low in salt and saturated fats. We need to maintain ideal body weight. It's important in controlling angina because excess weight increases the heart's workload. It's important that patient has a regular individualized program of physical activity that conditions rather than stresses the heart. For example, tell patients that walking briskly on a flat surface at least 30 minutes a day Most days of the week is recommended. It is important to teach the patient and caregiver the proper use of nitroglycerin. Nitroglycerin may be used prophylactically before an emotional stressful situation or physical exertion such as climbing a long flight of stairs.